Linda Thompson, Spokane Valley City Council.
Brian Beggs, Spokane City Council and Chair.
Ben Wicks, City of Spokane Valley.
Ray Byrne, Environmental Public Health Division Director and Interim Administrator.
Bob Lutz, Health Officer.
Andrea Frostad, citizen, appointed citizen.
Chuck Hafner, appointed citizen.
Mary Cuny, Spokane County Commissioner.
Don Condon, citizen.
Kevin Freeman, City of Millwood.
Josh Kern, Spokane County Commissioner.
Thanks everybody for being here. I think there's a proposal to switch our agenda around and defer public comment to a little bit, but we only have 3, and since people have come down, I'd like to just get that out of the way. I know some people have to leave to get to an STA meeting, but I'm hopeful just 3 people at 3 minutes each won't get us too far off track. So with that, I'm going to invite Jacqueline Gallion to the podium.
Hello, Jacqueline Gallion, City of Spokane Valley. Polio is an entero or gut virus and is transmitted by fecal-oral contamination, meaning you must ingest the contaminated feces of an infected person to contract polio. The countries where polio is still a concern lack basic sanitation, practice open-air defecation, are too poor for toilet paper, and have no facilities for hand washing after elimination. People will often defecate in or near water sources to have access for rinsing themselves. Historically, in the U.S., polio transmission was through poor sanitation, substandard water sources, hand hygiene, farm ponds and streams, and inadequate swimming pool maintenance. Today, the average American defecates into water with enough chlorine to kill a goldfish. In developing countries, polio infection by environmental contamination is considered a benefit by public health because it is a form of secondary passive immunization when the vaccine strain virus is spread through the community. Except because the vaccine virus is alive, when it is in the environment, it can and does mutate back to a virulent form and is responsible for most paralytic polio in these countries today. First world nations switched to a killed virus injectable vaccine because parents were contracting vaccine-associated paralytic polio when changing their recently vaccinated infants' diapers. IPV does not prevent polio colonization and excreting virus. The most recent polio cases in the U.S. were importations of vaccine strain. In Washington, there have been 5 cases of polio with no mortalities, all vaccine-associated since 1985. Between 1920 and 1982, the highest number of cases on record was 1952, with 1,320 cases, with 22 mortalities out of 2.5 million population. That same year, there were 232 Washington tuberculosis deaths. By the time vaccination was initiated in 1955 and 1956, case counts had dropped to 517 and 192. By the time the oral polio license in 1963, case counts were single digits. In 1955, Cutter Laboratories produced defective vaccine, which caused 40,000 cases of polio, disabled 200, and killed 10 children. According to the CDC Pink Book, 72% of polio infections are asymptomatic, 24% are minor, non-specific illness, and 1 to 5% fully recoverable non-paralytic aseptic meningitis. Less than 1% of infections lead to paralytic polio, and most recover completely. Understanding these facts, is it foolish or reckless to delay or opt out of a polio vaccine unless traveling to a third world country? I also want to add, which is not on here, is that another month is going by and I still have a request for roundtable discussions and being an action item at your meeting. So thank you very much.
Thank you, Ms. Gallion. And next I'd like to invite, looks like Ina M.
Hello, my name is Ina, and I'm from Spokane County. I'm here to speak.
Can you give us your full name just for the record?
Ina Mayora. and I'm here to speak up on behalf of my big and constantly growing Slavic community here in Spokane, Washington. Our community was very troubled by recent changes in regards to MMR vaccine requirement in order to attend public schools. As Christian parents, we oppose the elimination of personal exemption for MMR vaccine and any other vaccines that may be required in future, which are produced with aborted fetal cell lines. The Center of Disease Control, which is responsible for declaring public health emergencies, has not attested to any sort of significant risk to the health of the community at this time. What happened to the epidemic we had just a few months ago all over the state of Washington? Why all of a sudden, right after the law passed, we do not hear about those measles outbreaks? Did it go away on its own? As faithful Christians, to the extent that our unvaccinated children do not pose a threat to anyone, we refuse to use any products that take its origin in abortion. Using these vaccines and believing in its effectiveness constitute most sinful action against human life, and therefore we cannot participate in it. We, Slavic community, strongly believe that conscience is a divine law which is inscribed into the heart and soul of man by God. Also, we have more and more reports from Slavic families with limited English where they were manipulated or feared into vaccinating their children. Some medical facilities provide false information to their non-speaking patients, stating that all vaccines are mandated now, or worse, they're saying that if families do not get all vaccines, they will never be able to become U.S. citizens, or worse, they may get deported back. What right do those facilities have to speak to these patients like that? Just recently, I talked to a mom that was bullied by a medical provider into doing MMR vaccine to her child. Right after that, her child got sick with measles. When she arrived to her primary care doctor to report such adverse reaction, instead of getting help, she was instructed to stay home and wait until the infection goes away. She was told not to report anywhere or speak with anyone. So apparently, MMR vaccine does not always protect, but can cause measles. We Slavics value our freedom, including medical, and we will stand against any persecution to protect our children and families. We have a right to make moral, ethical, medical decisions. Thank you so much.
Thanks so much for sharing. And next, I'd like to invite up Natasha G. And could you also give us your last name for our records?
Sure. Hello, my name is Natasha Gurin. I'm from Spokane County and from Slavic community as well. So we need to stand up for our children now. It's only getting worse. The more the vaccine schedule grows, the more autism rates are climbing. 1 to 6 kids have learning disabilities, ADHD, more and more kids with allergies. We're supposed to have the best medical in the world, but we have the highest infant death rate in the world. If you look at the VAERS, Vaccine Adverse Event Reporting System, all the deaths reported go right along with the vaccine schedule. 2 months, 4 months, 6 months, 12 months, and so on. They're not passing away on the odd months, 3rd month, 5th month, 7th month, 9 months, etc. All these kids are passing away the same months as all their well-visit months, shortly after receiving vaccinations. Doesn't take a rocket scientist to see what's going on. They say less than 1% even know to report to VAERS because people don't even know what VAERS is. Pediatricians don't report adverse reaction because each one they do, it hurts their percentage number in order to get $40,000 incentive bonus in the end of the year. People don't even know that there is actually a vaccine court. It's a tragedy. Get your heads out of the sand. We should always retain our right to medical freedom, right? My body, my choice, except for vaccines. Glyphosate is bad, except in vaccines. Mercury is bad, except in vaccines. Aluminum is bad, except in vaccines. Philosophical freedom. Here we go, 2019, except for MMR vaccine.
one side does not fill all except with vaccines. Your consent matters except with vaccines. Transparency matters except with vaccines. All lives matter except the ones used to make vaccines. Thank you for listening.
Thank you, Natasha, and that brings us to the end of public comment. All right, we're back in session, and is there a motion that anyone has?
Yes, Mr. Chair, I move that Waldron and Spokane Regional Health District Legal Counsel be authorized to offer the position of administrator to Amelia Clark and engage in negotiations for an employment contract.
I'll second that.
Any discussion? Hearing none. All those in favor, please indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? All right. That.
Can we have a round of applause on this?
You can. Yes. Yes, a tremendous amount of work from our committee, from our staff, and our legal counsel in Waldron. Particularly, I want to commend Ann, because a lot of that falls on her on a daily basis. We have a quick consent agenda. I know some people have to leave. There's two things. Meeting minutes from June 27th and July 18th. Is there a motion in regards to that?
Move to approve the consent agenda as presented.
Any second?
Second.
All right, any discussion? Hearing none, all those in favor indicate by saying aye.
Aye.
Aye. Any opposed? Nay. Any abstentions? None. That's passed unanimously. And then is there a motion regarding the vouchers for June 1st through 30th, 2019?
Move to approve.
And second?
Second.
All right, any discussion? All those in favor indicate by saying aye.
Aye.
Aye. Any opposed? Nay. Any abstentions? Hearing none?
Me.
Oh,
My,
Yes.
my.
Councilmember Thompson is abstaining.
Abstaining.
Yep. But for the abstention, unanimously approved. Thank you, everyone, and I realize some of you are leaving to another meeting. Thank you for sticking around as long as you could. Okay, next up is a chair report, and the chair has nothing to report except that our auditors are here, and I think Commissioner Cooney is going to sign a letter that's saying she acknowledges our auditors are here.
Yes, I have done that.
Okay, that's great. Board of Health Committee reports. I'm going to defer the special committee because you guys have done your work, so we don't need you any. I will commend you to think about an onboarding process for the successful hiree, assuming the contracts work. So I hope you'll work on that. So a few more 7 o'clock meetings. The policy committee, Andrea has a report for that. Thanks.
So the policy committee meeting met on July 18th. Is that turned on?
Yeah.
Okay. All right. As explained at the last Board of Health meeting, Kate and Bob Lutz met and put together a series of points they saw as synergistic to the strategic plan, and these points were discussed again. There was discussion on how these points overlay onto the already existing programs and work being done within the departments. Well, as Kate stated, an overview of what the staff was working on was taken into consideration. More communication with the departments on the input they have provided or may still want to provide will be useful in understanding the plan overlay. This is the way that I understand it. So this way, policy will be specific by avoiding redundancy, identifying areas that may need change or support, and making sure nothing that needs emphasis is overlooked. So in summary, we are still discussing the strategic plan, priority areas, and fleshing out specifics and what focus areas will be pursued with policy. And then there was a discussion on combining the education and policy committees. Keeping them as separate committees was where I believe that we finished off because they were going to be separate anyways, even as a combined. So we're going to separate those. And Linda has volunteered to be on both of those committees. And so I don't know if we need to open this up again to establish an education committee. I mean, go back to that. And then the discussion revolving around RCW 4217A555 was mentioned again. At the May policy meeting, Bob Lutz stated that he and others would like to get Board of Health members to lobby for the agency. However, due to this RCW, Board of Health members are prohibited from lobbying. Very basic explanation for the Board of Health is for them to lobby. Appointed citizens cannot have voting privilege, and/or a change to the RCW would need to happen. At the last meeting, revoking voting privilege of appointed citizens was offered for discussion. However, it was agreed that further discussion should wait until or when Michelle Fossum can be present. And where did she leave? Okay. So, because at the May, and I just want to recap, so at the May policy meeting and stated at the last Board of Health meeting, it was requested to clarify lobbying versus education. I'll just repeat this part because this is for Michelle. That's good timing. So at the May policy meeting and stated at the last Board of Health meeting, it was requested to clarify lobbying and advocating and education. And then you stated that you would be covering this again, and that at time to time, you know, you revisit this issue and you send out a memo addressing it. But I think we're going to be, I'm assuming, am I got this right, that we're going to be talking about this at the Board of Health meeting? Okay, so there'll be more discussion on that. Because I believe it'd be effective for everyone who sits at this table at the meeting, so that there's understand and identify the clear line between the two, including me. So the next policy meeting is September 19th. That's our report.
Thank you. And I guess I just wanted to chime in on for Michelle, and we can talk about when, but I think there's two issues. One, there's a question in general, the difference between lobbying and public education, which, you know, is a term of art, and there's all sorts of factors. But then this other statute that Andrea was bringing up, which when I read it has to do with campaigns, either for individuals or ballot matters, but it wasn't for lobbying the legislature. And so there's two different kind of things to dive deep in. But we'll work together and get that figured out. So, any other questions or comments from the policy committee?
Well, and if I could add, I'm on the education committee as well, and what I said at the policy committee is I really would like to see the Board of Health be more informed of all the kinds of education and opportunities that are happening by the different departments at the health district, so that we could partake of that education, go to events, let us know either a calendar of events or something. I think that there's a lot of good education and events that are happening, and I'm just not able to track those without either some kind of a formal, here's an opportunity, the Neighborhoods Matter group is going to meet with neighborhoods to talk about this, or, you know, there's a clean air, something happening, so that we could be there, because I think the more we know about what is happening within our health district, the more we can educate folks to let them know. During our financial, which I guess that's coming up, the fiscal committee, one of our partners was mentioned, and I hadn't realized we had a partnership with the school district. And I thought, that's something I could promote and share when people say to me out in the community, well, who's dealing with this? And I could say, hey, there's a partnership with the regional health district and school district. So it's just about educating us and spreading the word for us to be effective leaders, to know everything, not that we could go to everything, but to be able to know what's happening as far as education, and then being able to go out. Maybe the Rotary invites us to go as a board member, and we could say, well, here's a program that's happening. Not that we would replace the staff for promoting, but that we could be educating the community as board members as to how folks could be supportive of programs at the health district. So that's one thing I see that I think the education committee could be doing to be supportive.
All right, so, and you're, just to be clear, you're on both committees, Linda?
Yes, I am.
Okay, so you're the liaison, but it might be helpful at some point that you all meet together once and clear that up. So I really appreciate people figuring out what's going to be most effective and bringing those recommendations forward. Anything from the Finance Committee?
I give an update of financial.
Okay, thanks, Mike. Any other, I don't think there's any other board committees. Then we'll go down to the administrative officer report. Ray.
Just a couple quick updates. One, I wanted to let the board know that we have hired a health policy specialist, Amber Lenhart. She's here today. And she... She currently is an employee with the health district, and she works in the data center now, so it should be a smooth transition. Right now, the tentative start date is August 16th, so we welcome her on board, and she will be getting to know the board well. So, and then update on the public information officer manager. So we have closed the advertisement for that. We've done the initial screening on that and should be moving forward with interviews here within the next week or so. So hopefully we can get that position filled here quickly also. And then just wanted to mention that Councilwoman Kate Burke, and a member of the board also, she visited the health district with the needle exchange program and treatment services, met with some of the staff there, and kind of got more in-depth knowledge of what we do. So we thank her for doing that, and also would like to welcome others if they have interest in doing that. If they want to know our programs better, reach out to Ann, and we can try and get something set up. Certainly within EPH, we have done ride-alongs and stuff with board members with that also, so we would welcome that. So that's all I have.
Thank you so much. Dr. Lutz, health officer report.
So to some degree, for those of you who are here, this is a repetition of last month's report. And the reason I bring it back to your attention is the fact that probably tomorrow, Department of Health will declare that there is a statewide outbreak of hepatitis A based upon CDC definition and based upon the Department of Health identifying that there are multiple counties that have individuals who have been diagnosed with hepatitis A. So, again, reiteration here, this is what hepatitis is, inflammation of the liver. These are symptoms. Again, individuals may be symptomatic or asymptomatic. Again, I like this little graphic, how you can remember the different types of hepatitis. Hepatitis A is a vowel, and it comes from the bowels, so it's fecal oral transmission. B, body fluids, and C, circulation, blood. Specifically around hepatitis A, this is how it's transmitted. And again, the sources are, as noted there, most oftentimes across the country where we've seen outbreaks of hepatitis A, it's been foodborne, and or it's been in individuals who have traveled to second and third world countries and contracted hepatitis A. With hepatitis A, there's no cure. It is vaccine preventable. And again, ideally, you can treat with post-exposure prophylaxis as soon as possible. This is existing epidemiology. And if I look right now at 2019, we have 11 or 12 cases across the state. We have, again, 9, and I'll point our own counts out in a minute. But essentially, the majority are here in Spokane County, with a couple over on the west side, primarily in Sea King and Snohomish at this point. So again, this is how outbreaks have occurred in the U.S. in the past. And this is important to note in that there has been a significant uptick in hepatitis A nationwide, and where we are seeing this specifically are in these populations. Again, in the MSM population, and again, with individuals who are either misusing, abusing drugs, and or are homeless. This map illustrates the states that are right now demonstrating that outbreak. I emphasize the very dark blue state, which is Kentucky. As of early in June, they had close to 4,700 cases. And I repeat that, 4,700 cases. They've had about 60 deaths of these individuals. And again, unfortunately, it was one of those situations which began in an urban environment, spread into rural areas, and with poor access to care, these people have not been treated and have succumbed to it. But again, I think the important thing to realize here, both nationwide and in our specific situation, is that this is really an issue around sanitation. You know, when I look at the risk factors, there are many, but again, recurringly, what we are seeing is that the individuals who are coming down with hepatitis A have that common denominator. They are limited in access to sanitation and sanitary facilities. So locally, as of yesterday, we have 9 cases, 8 of 9 who have been hospitalized. Common denominators, substance usage, homelessness. Demographically, 6 have been men, 3 women. Most have been white. Age range has been typically less than 40, but the median is 35. No travel, and only 1 of those individuals was vaccinated. This is, again, who should be vaccinated. I won't read this to you. Pretty self-explanatory. We use a couple of different vaccines. We have been very proactive at the agency to really reach out to local shelters, food areas, working with providers to make them aware of the benefits of vaccination. We use Twinrix, which is a dual vaccine. It provides vaccine coverage for both hepatitis A and hepatitis B. There is a vaccine just for hepatitis A. And what you'll see in a graph in a little bit is that we've been making use of that in some respects as well. But the nice thing about Twinrix is that, again, it addresses both A and B. The downside is that for really optimal efficacy for hepatitis B, you need to have a series of shots. It's at point 0, at time 0, within 1 month, and then ideally at 6 months. It's not always easy to get individuals back for those 2nd and 3rd shots. And that's sort of what this graph represents. So if black represents that first shot, you can see disproportionately very successful since going back to October when we started doing outreach efforts for, again, addressing hepatitis B, because we were seeing an uptick in Spokane County. Less numbers for both 2nd and 3rd doses for Twinrix. Since our local outbreak of hepatitis A, again, I commend staff and the community. We've done 336 vaccinations, but again, primarily dose 1 because we're not yet at that point where we're getting a whole lot of dose 2. Dose 3 may be individuals who we identified previously, and again, continued outreach efforts. But again, this represents, again, a local outbreak consistent with CDC guidelines and definitions, and at the DOH level, because it crosses counties, there's multiple counties, DOH will be releasing a press release tomorrow indicating that we have an outbreak of hepatitis A across the state. And that's why I wanted to bring it to your attention today. Again, the important thing, though, I want to emphasize, because again, we'll continue to have rhetoric around risk factors. Yes, individuals who are homeless are at increased risk. Yes, individuals who abuse, misuse drugs are at increased risk. But a common denominator in all of these populations is access or lack thereof of sanitation facilities. And part of our effort has been outreach effort, and Steve Main will not talk about this specifically, but through environmental public health, has been working very, very closely with shelters, with food services, where again, individuals are coming for assistance for services, working with those organizations to inform them about proper sanitation facilities, how you clean those areas to prevent transmission. And then those of you who were here last month remember that we had a good presentation on air quality. Dr. Sam Joseph, a pulmonologist, talked about some of the health issues, some climate issues. We had Lisa Woodward from Clean Air talk about the efforts that Clean Air is making and the collaboration between Clean Air and Spokane. It was a pleasure to work with Councilman Brian a couple weeks ago, where we had a meeting with Clean Air and some other individuals around issues around Clean Air specifically, but also around monitoring. And then last month, I did not get a chance to talk about a little bit what's been going on at the state level that I've been involved with. So this, for information, this is August of last year. This is looking off the roof. This is about an AQI of about 190, I think. Specifically, at the state level, there's been 3 work groups as part of this wildfire smoke impact working group. There's been one that's been working on monitors and sensors. There's one that's been working on education and trying to get consistent education across the state. And then specifically for me and my other colleagues, health officers, we've been working in what's called a closures group, specifically looking at what we would do, what recommendations we would have, when we would provide those recommendations to schools around indoor air quality and events such as sporting events, such as food events, such as Pig Out at the Park, around outdoor air quality. These are, again, some of the things we've been considering: health concerns, factors, and then again specifically focusing on PM 2.5, which again you heard about last month. Ultrafine particulate matter, 2.5 microns, gets deep into the lungs, causes inflammation, can actually pass through the lungs into the circulation and cause inflammation throughout the body. As I will continue to iterate, there is no such thing as a safe level of PM 2.5. So although we focus a lot on at-risk groups, such as the young, such as individuals over the age of 65, pregnant women, people with heart and lung disease, you can be healthy. You can be a triathlete. You can be a long-distance runner. You can be a young person, but you are still at risk for PM 2.5. What we in the closure group have come forward with, and again, I emphasize this is still draft, it's still working its way up through Department of Ecology and DOH, is that when we have a PM 2.5 level over 35 micrograms, then we would talk to schools and have them consider changing the venue for athletic events and practices to an area of better air quality. That could be practicing inside, that could be going into the gym, that could be going into the training room. But essentially, because young people are one of those at-risk populations, we really would encourage them to strongly give consideration to changing the venue for their activities. This would also include PE, physical education. 80.4, okay, and I'll talk about that number in a bit, but essentially, we would encourage organizations, outdoor events, vendors, okay, to consider canceling or rescheduling an event. And I emphasize the word consider. We're not drawing a line in the sand. We just want people to start giving this a consideration. Because of the fact that there is no safe level, at-risk groups, we can't control what people are going to do, but we want people to start being aware of the fact that they are putting themselves individually and collectively at risk, and therefore we are going to encourage them, okay? At a greater than 150.4, we are going to strongly recommend canceling an event. Again, no lines drawn in the sand. We are going to strongly recommend. And the reason those numbers have been identified, too small, but believe me when I say this number here is 35 and 35.5. So I'm now getting into this unhealthy, and it's unhealthy for everyone. It's not unhealthy just for at-risk groups, it's unhealthy for everyone. So that value is consistently one that has been shown by research, looking at, again, 24-hour levels, where we will see health effects for everyone. Therefore, we thought that was a good place to start. Okay. Very unhealthy goes from 80 to 150.4. Okay. Just a little worse, but not good for anybody. 150, you get down into this hazardous. It's hazardous for everybody. This is extreme caution, folks. And so therefore, we're not going to quibble about this. We really want to strongly encourage this. Right now, again, I emphasize strongly encourage. But in a couple of years, as more evidence comes out, as more people are aware of these recommendations and guidelines, there may be a little bit more strict language about closure of events and activities. So that's where we are right now. We had hoped to have a final document available about a month and a half ago. It should be, hopefully, knock on wood, available by the end of this month. And once we get that out, I'll be forwarding that to everyone so you know that. It's also going to be imperative that we work on educating the public, educate individuals and stakeholders, so that they are going to, again, be well informed about what to do. I don't want to have a health officer order to have a closure of an event. Rather, I'd have people sort of self-select and have stakeholders say, you know, maybe not today, maybe tomorrow. So, any questions? Wow. Okay, yes, I'll. Oh, Andrea. We did get up over 200. We were in hazardous for a couple of days. I would encourage you, and I can send you directly to Clean Air Agency's website, but they have a link that shows you exactly how many days per year and the date and the level that was reached during that day. What's interesting to note is that you go prior to 2012, you see nothing. Since 2012, a lot more days. 2016 was an anomaly. We saw a lot of bad weather in 2015, not much in 2016, 2017, and 2018. But I want to say last year we hit a high of around in the 200 range. Yeah, yeah. Yeah, it's all great questions. And I think that's where part of these conversations need to begin and need to sort of evolve. You know, so again, I emphasize the fact that we're talking about, for schools, air quality indoors. Now, then it depends upon their HVAC system and whether or not they're able to filter the air properly. And is indoor air better than the outdoor air? Sometimes. And then you have conditions that, for example, if you have schools that don't have an HVAC system, so they're having to close the windows, but then it's a hot day and then you're having heat issues. Is it better that the school considers sending the children home? And then you have to question, well, what happens if you're sending children home to environments that don't have air conditioning? So you can see it's a conversation, and it's not black and white. And so, again, this is part of why we're getting this information out there now, so we can have these conversations with the superintendents and the stakeholders so that they're making informed choices.
Hard to answer mine. I was concerned about how things were indoor environments. It seems to me that would be quite variable.
Incredibly so. Right. Now, I mean, again, you're absolutely correct, and I think this is part of the education process. Right. I mean, I attended a conference last year, and there were representatives from EPA, and one of the points they made was that without exception, unless you are opening windows and allowing the outdoor air to come in, going indoors is going to be a better situation than exposing yourself to this, I should say out there. But again, it's a continuum. And so if you are indoors and you're trying to using your air conditioning unit, well, you want to put it on recirculate. You don't want to be bringing the bad air in, which is, kind of self-evident. But you also don't want to be dirtying the indoor air. And we have FAQs around this. Our website, we just updated our FAQs. So you don't want to worsen indoor air by fry cooking or vacuuming, things like that. But yeah, there's a lot, believe you me, there's a lot of learning that I think people have around this issue and becoming better informed about what to do and what not to do.
I was wondering about if there is a formal partnership or discussion with like building code folks or schools to really talk about how clean the air is, because in some areas of poverty where their schools haven't been updated forever and ever, I'm not sure it would be that. I mean, obviously being indoors might be better or it might not in some schools. So is there any partnership on the public health administrators who are at your group to talk with other entities who could be part of the solution?
So I will go backwards a little bit and speak specifically to what we have going here in Spokane. So one of the program managers in environmental public health, Julie Aubrey, she leads a facilities work group that works with the schools, ESD, the schools throughout the area to look at issues. She and I have been in conversation. She's been part of some of these conversations. They've been very interested in this because of obviously how it's going to impact them. They may be looking to have to retrofit some of their facilities. And or going forward, if you have new facilities being built, should you be ensuring that the schools have appropriate HVACs to prevent this issue from being a problem? So, yes. There have also been, but I would also share with you, ma'am, that if I look at a state level, yes, we have had representation from a variety of sectors to include facilities individuals to, again, factor that in. Thank you.
Going back to your chart of various concentrations, was that just everyone agreed with that, or was there any discussion about moving it up one category on each of those?
There was plenty of discussion.
Yeah. Was there any proposal to go up one? Because I could see it easily just moving up your numbers one category for each of those.
Yeah, it was. We actually, early on in the conversations, looked at having more stringent criteria. We also were very dependent upon the existing science. And so the data that we had suggested right now that these cut points were appropriate at both, I've mentioned to you before, you've probably heard of the fact that there's two different criteria that are oftentimes referenced, the AQI, Air Quality Index, and the WACA, the Washington Air Quality Assessment? I always with the A. No, it's an A, WACA. Bottom line is that there's a disparity between those cut points. We all agree that at certain levels, you start to have these issues, but again, there's been a disparity between where those cut points exist. When we looked at these values, however, we felt that these values were consistent across both of those indices that said that when you get into these unhealthy ranges, then you started to make the recommendations. So based upon what existed previously and based upon existing data, that's where we decided to sort of put down the cut points. There are other data that have not been finalized, which may make some changes in this for next year or the following years. And as I've mentioned before, and will continue to mention, this is evolving science. We haven't had to deal with it historically in the past. We are now having to deal with it presently and going forward. It's also interesting that not all PM 2.5s are created equal. So a PM 2.5 from wood fire smoke in the Northwest is different than a PM 2.5 from wood fire smoke in the Northeast because of what has been taken up by the wood. Where, for example, back east, I have more problems with acid rain historically. So in the Idaho basin, where I have more issues around metal leaching, metals that have gotten into the soil. So I now know that I have those metals in the wood, and that gets burned. Not a big issue back east. Lots of research out of Finland. Woods are different in Finland. Woods are different in California. So what we've been encouraged to do is to look at the data that are available in the Northwest, to include British Columbia. And there are data that are coming forward that have not been finalized, which may make some changes in these values for us. But right now, this is where we decided to settle.
So what I'm just curious about the rationale, if very unhealthy, it seems like, and that's for all groups, not just special groups. So why wouldn't you recommend canceling it very unhealthy? I'm just curious as what the discussion, what was the rationale for not recommending canceling when it's very unhealthy for all? That's my question, I guess.
If you look, again, I think it's, what I've said before is it's difficult to draw the line in the sand when when nobody knows that there's actually sand to draw a line in. And just based upon the science right now, we felt that 80.5 was where we were going to start recommending. And again, I emphasize the word recommending. If I have, and again, this goes back to Andrea's question, if I have 10 days of 90 or 100, then I'm going to be talking with DOH and talking at a state level. What do we think we should be doing when I've got 10 days above this level? And there may be recommendations that say, yeah, you as a health officer should now just not consider, but actually should recommend and/or make it happen. But we're not at that point right now. But 80.5 definitely, we actually early on, Brian, suggested that we were going to go back to 35.4. So our initial push as health officers, looking at the data that we were looking at the time, said we need to go back at 35.4. But we were also looking at preliminary data. When we looked at all the data, and then again got feedback, and again, real kudos to the folks at DOH who've really been sort of shepherding this process. They talked to a lot of experts across the country, at UW, up in British Columbia. Where should we make our cut points? And this is what was the general recommendation.
Thanks. All right, thanks for sharing that, and welcome back to town. I don't know, is there anything in the legislative report, or is that just, I don't think there's at this point. But soon we'll be hearing from you about that. That's great. Mike, financial report.
Yes, thank you. The Budget and Finance Committee did meet. We got together for a couple hour and a half meeting. And a couple of things we went over was this is the time of year where if the staff brings forward any recommendations to the fee policy to make any fee policy change, that would happen at this month's meeting, and I'd bring it forward to you here. There was no recommended changes, and so as we went through the Budget Finance Committee, as you know, so we're sort of doing this, our fee policy will stay the way it's been the last few years, and we really strive to try to get 100% reimbursement on our fees based upon the cost to run that program or run that particular service that we're providing. And so we'll continue forward. So we will be moving forward and bringing to a fee schedule for you at the September meeting when we reconvene. So that's one thing we went over. The other thing I was asking the Budget and Finance Committee was what type of reports they want to see at this meeting. I know I've been coming in sort of ad-libbing reports the last couple months and bringing stuff up that I thought was interesting. But I said, is there any other stuff you want to see, and welcome any suggestions. I did say that I was going to send out in your packet and on the board in front of you. This is our 2019 year-to-date, based upon how our actuals are doing to our budget. And big picture, don't have to get down to the details right at the moment, but as you can see, our expenses are running at 52%, which is more than halfway over our expenditure authority for this year. And the good news is, as you move down to the revenues are at 54%, so we're actually pulling in the revenues faster than we anticipated. There's a couple reasons for that. Some of the programs are the ones that Councilmember Thompson was just talking about, where the school district money that goes out to the school districts comes into us. We pass that through to providers, and those providers do the work. Well, it's all based on a per-child rate, and of course the number of children that are in each school district area to get those services done, and those are rising beyond what we anticipated. So there will be a budget amendment coming in September also to this board for the 2019 budget. Definitely in that program, and possibly in a few other ones where we have to make some minor changes, but we will probably be asking for a little more budget authority to account for that situation coming up. Other than that, you have the report both by the agency and by division, and so feel free to, if you have any questions on that, get a hold of me and let me know if you have any questions on those items. Another request that came from Councilmember Thompson was she would like to see some type of list of some of the vendors / contracts that we do business with. Who do we give our money to, and who are we partners with? And so I compiled the original list. I had both the 2017 and the 2018, all the vendors we gave any money to. That's a pretty large list. So I went to the exec committee of the board last week and asked them, what type of report would you like me to give? And so what you have in front of you is an alphabetical list of all the entities that we give $50,000 or more to. There's 33 names on there, and it gives us a good list to start. If you want to see more than that, feel free to either come meet with me or give me a call on the phone, and I'll go over it. Or if you have any questions about what we're paying these people, what type of service we're buying from these entities, feel free to come here and sit down, and I'd be glad to spend some time. I also was able to spend a little extra time after the Budget Finance Committee with Citizen Frostad it was very good dialogue. Thank you for coming and being interested and wanting to know about how the health district works and where our funding comes from and how we are good stewards, financial stewards of that money. So I appreciated that. Then lastly, as already mentioned by Councilmember Beggs, is the auditors are here in sight. The one question I had to bring to you today was, in the past, it was always mandatory, and now it's optional of whether you want to have a audit entrance conference with the auditors. It's not mandatory. We haven't done it the last 2 years. All they do at this meeting is they sort of tell you how the audit's going to work and announce which program they're going to take a deeper dive into. Well, I can tell you that today they picked the Women, Infant, and Children WIC program, so that's what they're going to be doing their big work on, besides all the other work they do to check our financials and our financial reporting and all that. So I don't see a need for the audit entrance unless somebody here absolutely feels like we need to have one. And of course, there will be an audit exit. That's mandatory. There will be an audit exit that will be announced to all of you, and you'll be welcome to come attend. But that is my financial report, unless you have any questions.
Just a question kind of going on the contracts. Is there a threshold that the contracts would have to come back to the board for approval on, or how do you, are they simply just staff kind of?
We don't have that in our policy or in our rules or laws at that currently.
So there's no dollar threshold that causes a contract to come up for board approval then?
Not by any policies that's passed right now.
I guess I would encourage us to maybe consider that. I know as a city and the different agencies that we do, we have, not trying to question your decisions on contracts, but just kind of our fiducial responsibility as a board to kind of have a set threshold of, if it's over, like I think our city is, we give our city manager $300,000 is his authority level, and anything more than that just comes to the board for approval, and then he can still sign the contract, but just keeps us in the loop to make sure kind of the checks and balances and more authority level there. So.
And I could bring that to the next Budget and Finance Committee, and we can start with that, and then see if there's a recommendation to move forward past that to the Exec Committee, and then bring. So we're going to meet on September 12th as the next Budget and Finance Committee meeting.
I was just going to mention the challenge of that is at the city we meet weekly, so we can do it pretty quickly if we're only meeting monthly and we don't meet every month necessarily. So that, I think that's why it hasn't been, but there's other ways. I mean, we do our circulating the vouchers every month so that people can look at that. So that's why it's a little different, I think, but it's a great point. Anything else? All right, thanks so much, Mark.
All right, thank you.
All right, Mr. Main, you're going to come talk to us about food rule revision updates.
Good afternoon. You've got about 4 handouts, I think, in your packet there. And before we get to the first handout, where it shows the Food Safety Advisory Council, I wanted to make a couple of important points just really quickly. The first one is that this is a statewide rule. It's called the Washington State Retail Food Code. It's adopted by the State Board of Health. And as such, the State Board of Health is responsible for the revision process, the rule revision process. And a number of years ago, back in 2003, this is another important point, the legislature actually mandated the State Board of Health to consider the most recent version of the FDA Food Code. In our case, that's the 2017 FDA Code. And there was some intent there, and that's also outlined in the RCW, which is that the United States Food and Drug Administration's Food Code incorporates the most recent food science and technology. The code is regularly updated in consultation with the states, the scientific community, and the food service industry. The Food and Drug Administration's Food Code provides consistency for food service regulations, and it serves as a model for many states' food service rules. It is the legislature's intent that the State Board of Health use the United States Food and Drug Administration's Food Code as guidance when developing the food service rules for this state. And so that's kind of where the process starts, is by considering the most recent version of the FDA code, okay? And about a year and a half ago, the State Department of Health was directed by the State Board of Health to assemble the Food Safety Advisory Council, which is that first handout that you have there in front of you. And there are 14 voting members, and the purpose of that is to ensure that there's equal application of the rule once it's adopted. But in this situation here, the rule revision process, our task as an advisory council is to compare the current rule, which is based on the 2009 FDA code, with the 2017 FDA code, and then see how the current rule can be modified, and adapted to pull across some of those requirements in the 2017 FDA code to make it better in terms of food safety. And so that's exactly what we've done. We've had 12 meetings now. And as you can see, there are a number of individuals there representing various stakeholders. There are 4 representing local public health. I'm one of the voting members. Lisa over there is my alternate. And of course, there's someone from FDA, DOH, and academia, someone representing consumers, and then the food service industry. We've had some great discussions about what's in the 2017 rule and what's in the current rule, and some measures that need to be pulled across to address some known and emerging food safety related issues. So the next handout there is a nice colorful one. What that is the timeline for adoption of the rule. Okay, so today, right at the bottom, it shows where we are right now in the adoption process. So draft 1 of the rule was made public on May 31st of this year. It was sent out to various stakeholders. We've kept our local food advisory committee completely up to speed and updated through this whole process. We just met with them again this week. We've been emailing them documents, and so they're very aware of what's going on. Comments on draft 1 of the rule are due at the end of this month, and so we'll be collecting those comments, and we'll be submitting our own comments to the State Department of Health regarding draft 1. Then we'll meet together again as a Food Safety Advisory Council on September 25th. At that point, any comments that have come across from the general public and any comments that I've received from stakeholders will then be put forth in a motion to consider for draft 2 of the rule. Okay? So we're still very much in the comment process right now. I wanted to make you aware of that aspect of it. Once draft 2 is finalized or formalized, it'll go to the State Board of Health in November. And at that point, the State Board of Health will be fully in control of the rule revision process. They'll perform what's called the economic impact study, and there will be formal hearings as well to hear public input regarding the rule before it's formally adopted. We expect implementation of the rule to occur November of 2020. Okay, but we also expect the rule to pretty much be finalized, frankly, by around January of 2020. So that kind of gives you a timeline of where things sit. The next thing, this next handout, oh, yes.
I just want to know how many folks came to the July 17th presentation, the public presentation and comment event?
Here in Spokane?
Yes.
Was about a dozen? Maybe a dozen? Yeah. Mm-hmm. Mm-hmm.
Mr. Halley was indicating that he was there, and there were 14 people.
Okay, excellent. In a minute, I'll tell you what we've done as far as a program to notify our stakeholders, not just about the meeting, but about the rule revision process itself. Okay. I'll kind of get to that at the end, okay? But I wanted to bring to your attention item number 1 here, which is a requirement that the person in charge be trained. We call that a certified food protection manager, and that's formalized training. It is not in our current rule. Okay, so this is a new requirement. It made its first appearance in the rule, in the FDA code, I should say, in 2013. And at that point, the mandate in that FDA code was that there be one food protection manager at each food establishment. In 2017, FDA changed it, and they changed it to one certified food protection manager per shift at each food establishment, which that change created a lot of discussion, as you can imagine, in the Food Safety Advisory Council regarding potential impacts associated with that particular change. There is a fee for the training itself. So there's a training phase, and then there's a certification phase. The total cost is roughly $200 to $300 per person. And so there's a lot of members, I shouldn't say a lot, but there's some members of the committee that thought that that was expensive, to be blunt. And however, there is data from FDA that shows that there is an improvement in the level of food safety at food establishments that have someone who is trained and certified at each location. Okay, there is specific data. And the more training and certification that occurs among more people, the better the data looks. Okay? So as a compromise, what the Food Safety Advisory Council decided to do is to go back to the 2013 requirement in the FDA code to where one certified food protection manager will be required for each establishment. There are some exemptions. So in other words, some food establishments would be exempt from that requirement because of the simplicity of their menu and the type of food service that they're providing. But it is an accredited program, and that requirement would go into effect July 1 of 2021 if it stays in this current version of the proposed rule. So another one that caused a bit of conversation was a requirement for date marking, which is item number 5 on your sheet there. Currently, date marking is not required in our code, and what that means is that when you're preparing potentially hazardous foods, or you're pulling it out of the package and storing it in your walk-in cooler or other cooler, the requirement would be that you put a date when the product would be pulled. It would either need to be consumed by that date or pulled. So there's going to be a lot of training that's going to be required for that implementation. And there, again, are going to be a lot of exemptions, but still needs to be worked out as part of this process of adopting the rule. One last thing, and that is potlucks. Currently, a potluck is allowed. They are exempt under our current rule if it's for a small group of people, like parishioners at a church. It's not for any kind of commercial gain. It's not advertised to the public. There's no charge, advertising is new. So there's no charge for the food or for the event. Okay, so the added language here, which is new, is that if there's any advertising, whether it be on a street sign, on a sidewalk, in a newspaper article, radio, television, or on the internet, it would no longer be exempt. And the reason that caused a lot of conversation is because there are a lot of methodologies nowadays that people use, whether it be private Facebook pages or whatever, to advertise their potluck event. And so I don't know that this is going to stay in the rule, but it's in there now. So in this particular draft, These are the three things that I thought you might want to be aware of. You might have some questions later about and some other ones, but to kind of answer your question about how we've notified our stakeholders, this is what we have done. As I pointed out earlier, we've made our Food Advisory Committee very aware of these updates throughout the process. We've talked to them during our regular meetings and sent them emails. Additionally, we started sending out a flyer during the, when we send out application packets for renewal of permits, we included a flyer that looks just like this one, actually. And it tells them that the rule is being revised. It told them about the public meeting we had on the 17th. But it also refers them to a website that they can look at that's on the DOH website that very nicely outlines why the rule is being revised. It gives them the documents that they can look at so they can see what changes are about to be made or are proposed to be made. In addition to that, we contacted our representatives here locally for the Washington Hospitality Association and the Washington State Food Truck Association to let them know about the rule revision. And then we sent an email out to all of our owners, letting them know about the revision with a link so they could go to the DOH website and see those potential changes as well. So, as I stated earlier, the deadline for comments to DOH is the 31st of this month. But of course, if anyone wants to send comments to me directly, I'll take them to that meeting on the 25th of September. So, the last thing is the website itself. So anyone can go to that website, which is doh.wa.gov/foodrules. When you go to that website and you go out to the upper right, you'll see a link to the rule revision process, and it outlines, just as it shows on this particular handout, the reason for the rule revision, the timeline, the proposed changes, and that kind of thing. So with that, are there any questions?
Seeing none, thank you so much for the comprehensive presentation. And
you're welcome.
My understanding is people can contact you if there's people who have questions. You're both for our local person, but you're also on the state.
That's correct. Yes,
so,
they can absolutely contact me.
All right, I'm sure Mr. Hatley already knows you, so he knows where to find you. So,
yes.
Excellent. Thank you so much, Mr. Maine.